Welcome back to the deep dive. Today, we are undertaking what is really a critical inspection of the ultimate architectural blueprint.
The human body itself.
The human body, exactly. We're looking at histology, but not, through the lens of dull diagrams. We're framing this as more of a high-stakes structural engineering report.
Right.
We're analyzing the microscopic foundations, the tissues, the cells, whose failure dictates some of the most devastating diseases we see in medicine.
That really is the core insight, and it's what makes this knowledge so high yield for you. Histology is the necessary link in that chain. Structure leads directly to function, which then, gives us that predictable disease outcome.
Okay.
Our mission today is to give you a shortcut. We're focusing only on the most essential building blocks, the specific collagens, the critical anchoring systems, and of course, the pathognomonic findings that tie that microscopic failure directly to what a patient presents with.
We've got 3 crucial phases to our inspection. First up, we tackle the body's deepest concrete slab infiltration system, the basement membrane.
Then it's collagens.
And its collagens. Second, we'll move up to the cell's surface machinery, cilia, microvilli, and all the junctions that hold everything together.
Mm-hmm.
And finally, we'll examine the specialized construction crew, our connective tissue cells, and specialized tissues. Let's start at the very bottom, securing the foundation.
The basement membrane, or the BM. It's often overlooked, but it is absolutely the essential anchor. It's a specialized extracellular matrix that every single epithelial cell has to rest on.
So everything starts there?
Everything starts there. And functionally, it does 2 massive things. 1, it anchors the entire epithelial layer to the connective tissue underneath it. And 2, crucially, it acts as a selective filtration barrier.
Which is a huge deal in the kidney and the lung.
A huge deal. Absolutely critical.
And this is where we really need to lock in that 4-3-7 rule for the collagens. These are the proteins that actually build this foundation.
Exactly. They aren't just random. Each one has a very specific structural job.
Okay, so let's start with type 4.
Type 4 collagen forms the basal lamina. This is the layer made by the epithelial cells themselves, and it's a primary element that handles both support and, critically, those filtration duties.
So that's our concrete floor and the filter, all in one.
Got it.
But, a floor needs a foundation beneath it.
And that's the reticular lamina.
Yeah.
It sits just beneath the basal lamina, and it's built from type 3 collagen, which you'll often hear called reticulin.
And that's made by different cells, right?
Right. It's produced by fibroblasts in the connective tissue below. This layer is all about bulk structural strength. Think of it as the steel mesh reinforcement in the concrete.
Okay, so floor, foundation, now we need to hold them together.
With bolts, those are the type 7 collagen molecules. They form the anchoring fibrils that literally bolt the basal lamina, the filter down to the reticular lamina, the foundation.
That makes perfect sense. If you understand those 3 roles, then you can predict the diseases when one of them fails.
But before we jump to the failures, let's talk about how you see them. A clinician sends a kidney biopsy to the lab. What are they looking for?
The key stains.
The key stains. The PAS stain is very high yield because it highlights the basement membrane, specifically the glycoproteins in that basal lamina. But if you want to see the type 3 reticulin meshwork for structural problems,
you'd use a silver stain.
Exactly.
Okay, foundation built. Now let's break it. What happens when the filter layer, type 5e collagen, fails? We've got 2 main ways, right? Autoimmune attack and a genetic defect.
Let's start with the immediate disaster, Goodpasture syndrome.
The autoimmune one.
Right. It's an autoimmune process where the body develops antibodies against its own type 5 collagen.
And where is type 5 collagen most exposed?
In the thinnest barriers, the glomerular basement membrane in the kidney and the alveolar basement membrane in the lung. So you get damage to both organs at the same time.
Which gives you that classic clinical vignette you always see. Hemoptysis plus hematuria.
Bleeding from the lung, blood in the urine.
And the pathognomonic finding, the one you have to know for your exams, is that linear IgG deposition on immunofluorescence.
It looks like a clean, continuous green line of antibodies painted along the GBM.
Right. We used to remember it as Goodpasture gives you that clean, linear pattern.
Now let's contrast that with Alport syndrome. This isn't an attack from the outside. This is a genetic defect in how type 5e collagen is built in the first place. The structure is just wrong.
So if it's not an antibody attack, the immunofluorescence would be normal, correct?
Precisely. That is the crucial diagnostic point. Immunofluorescence is normal. There are no antibodies to stain. But if you look closer, under an electron microscope,
you see the physical destruction.
Yes, you see the classic basket weave or split appearance of the GBM. The structure is literally fraying and breaking down. And outport isn't just the kidney. Type 4 is also key in the cochlea and the lens.
Giving you that famous triad: kidney failure, hearing loss, and eye problems like anterior lenticonus. So that distinction is golden. Good pasture. Linear IF output. Basket weave EM. But what about our bolts? What happens when type 7 gives way?
That's epidermolysis bullosa. A defect in type 7 collagen means those anchoring fibrils fail.
So the floor just lifts off the foundation.
It's a perfect analogy. The epidermis lifts completely off the dermis. The buzzword you'll hear is skin sloughs with minor trauma. It leads to just devastating recurrent blistering because there's no adhesion.
Okay, we've covered the foundation. Now let's move up and inspect the surface, the interfaces, the tools the cell uses to move, absorb, and stick to its neighbors.
We're looking at 3 major apical projections, and it is vital to know their internal skeleton. That's what determines their function.
Okay.
Cilia are based on microtubules in that classic 9+2 arrangement. Microtubules are like the railroad tracks of the cell, so cilia are inherently motile.
Their job is to move stuff.
Move fluid, move debris. Think of the mucociliary escalator in your trachea, or moving the ovum down the fallopian tube.
So when those motors fail, specifically the dynearm protein, we get Cartaginer syndrome.
Immotile cilia.
Right, which means chronic respiratory infections because you can't clear anything, and infertility. It's a total failure of the body's little conveyor belts.
And you have microvilli. They're built on actin filaments, not microtubules, so they're completely non-motile.
And their whole job is surface area.
Axomized surface area for absorption. They form the brush border in the small intestine and the proximal renal tubule.
And here comes the trap, the one the exams love: stereocilia.
That name is so misleading.
So misleading. They are not true cilia.
They are also actin-based and non-motile. They're essentially just really, really long microvilli.
And you find them where?
Absorption in the epididymis and mechanosensation sensing movement in the inner ear hair cells. The bottom line is, if you hear motile or 9+2, it's microtubules. Anything else is actin.
Got it. Okay, beyond projections, we need to check the seals and anchors between the cells, the junctions.
And we can memorize their arrangement from top to bottom, apical to basal, with the mnemonic TAHG.
TADA-HG. So the T is for tight junctions, or zonula occludens. They use actin, and they are like the ultimate security zipper.
They seal adjacent cells completely. No paracellular leakage. It's all about compartmentalization.
And when that seal is broken,
fluid goes where it shouldn't. The classic example is cholera. The toxin specifically targets and blows open the tight junctions. This leads to that massive, unrelenting, watery diarrhea. The small intestine basically becomes a leaky gut.
Moving down the line, we hit A for adherence junctions, also actin-based.
Yes, and these are for mechanical linkage, helping groups of cells move and act as one unit. Defects here are implicated in things like arrhythmogenic cardiomyopathy, where the force transmission between heart muscle cells is compromised.
Okay, now for the serious structural stuff: desmosomes and hemidesmosomes.
Both of these use the body's real scaffolding intermediate filaments like keratin, but their targets are completely different.
Desmosomes attach cell to cell.
And hemidesmosomes anchor the cell to the basement membrane.
And this one difference creates 2 totally distinct, highly testable blistering diseases.
Let's start with pemphigus vulgaris.
Failure of the desmosome. Cell to cell.
Right. Autoantibodies attack desmoglein, the glue between the cells. This causes a weak intraepidermal split. The blisters are flaccid because they form so high up.
And the pathognomonic finding on immunofluorescence.
The fishnet pattern of IgG outlining every single cell.
Now, compare that to bullous pemphigoid. This is the hemidesome failing.
The anchor to the basement membrane. Autoantibodies target the integrin proteins down there. Because the entire epidermis is ripping off the foundation, the split is subepidermal.
Which means the blister roof is the whole epidermis. It's thick.
So the blisters are tense and robust, and the IF shows a clean linear IgG pattern right along the BM.
So if you see a question about tense versus flaccid blisters, you know immediately if you're dealing with a hemidesmosome or desmosome failure. It's structure dictating diagnosis.
Exactly. The last one is the gap junction. They use connexin proteins to allow direct communication between cells.
Little tunnels.
Little tunnels for electrical signals and small molecules. They're vital for synchronized action in tissues like cardiac muscle. If they fail, especially in the heart, you get conduction defects and arrhythmias.
Okay, foundation, surface machinery. Now for the specialized builders and high-yield tissue correlations. Let's look at the connective tissue cells. the immune system's first responders and the body's fabricators.
Let's start with the fabricators. Fibroblasts make the extracellular matrix collagen, elastic fibers, the whole shebang. Then you have the immune cells,
Like plasma cells.
antibody factories. You can spot them by their eccentric nucleus and that distinct clock face chromatin pattern. Seeing a lot of these usually means chronic infection or pathologically, something like multiple myeloma.
And the body's alarm system,
Yeah.
the mast cells.
They are just loaded with histamine. When you stain them with toluidine blue, they're dense granules stained purple red, which is a phenomenon called metachromasia. They are the rapid mediators of allergy.
Right. And the cleanup crew.
The macrophages, professional phagocytes, when they eat a lot of fat, say in an atherosclerotic plaque, they become those recognizable foam cells. They're also essential in chronic inflammation, where they fuse together to form giant cells in granulomas.
We should also quickly touch on how glands work, using the MAH mnemonic for secretion, M for merocrine.
That's the most common, simple exocytosis. The cell just ships out its contents without any damage to itself, like in sweat glands.
A is for apocrine.
This is where the apical or top portion of the cell is pinched off with the secretion. You get that cytoplasmic pleb being released. The classic example is the mammary gland releasing fats.
And H is for holocrine, the most destructive mode.
The whole cell disintegrates to release its oily contents. This is how sebaceous glands make sebum. The sebum is the broken down cell.
Let's do some quick points on muscle. The key distinctions are striations, control, and nuclei.
Skeletal muscle. Striated, voluntary, multiple nuclei pushed to the periphery. Smooth muscle. Non-striated, involuntary, spindle-shaped.
And cardiac muscle just jumps out at you. Striated, involuntary, central nuclei. But the pathognomonic feature is the intercalated disc.
Yes, they show you exactly where one branched cardiac cell meets the next. Absolutely essential for synchronized contraction.
Finally, the nervous system support network, the glia.
Neurons themselves are distinctive for their big nucleus and their Nissl bodies, which are just very active, rough ER. But for myelination, you have a critical CNS versus PNS difference.
Oligodendrocytes in the CNS,
They myelinate multiple axons,
while Schwann cells are in the PNS.
and they myelinate only a single axon, and the high-yield trap in the PNS is the satellite cell.
Right. What are they?
They're the small, flattened support cells that surround the neuron cell bodies in the ganglia. They handle all the metabolic needs of the peripheral neurons. They're often the trick answer on an exam.
Let's pull all these microscopic failures back into one last epithelium.
And the mission here is to connect everything, location, function, and even disease using embryology.
Specifically the 3 germ layers. That's the central rule. If you know the architect, you know the building, and you know its weakness.
Okay, but before we jump in, we have to tackle what the sources all highlight as the single biggest point of confusion. It's the trap the examiners just love to set.
Oh, absolutely. The foundational rule is that all 3 germ layers, endoderm, mesoderm, ectoderm, all of them can and do form epithelial tissue.
Right.
But the confusion, the trap, is confusing endoderm with endothelium.
Oh, they sound so similar.
They do, and it's a critical difference. Endoderm lines your GI tract, but endothelium, the lining of your blood vessels, that's actually mesoderm, radically different origins.
So getting that distinction right is basically the ticket to entry for this whole deep dive.
It is.
And if we simplify this whole world of epithelial tissue down to those 3 architects, we get this massive shortcut. Endoderm is the inner plumbing.
Right. Focused on absorption and secretion.
Mesoderm is the slippery wrap for movement and vascular lining.
And ectoderm.
That's the exterior armor. It's all about
Okay.
protection and defense.
That's the whole map right there.
Okay, let's unpack this then. Starting with endoderm, the architect of the inner plumbing of the body. So if it's a vital tube or a duct deep inside your body, especially for, say, digestion or respiration, that's endoderm territory.
The best mnemonic for endoderm is E for enteric and glandular. This layer lines the entire GI tract. It forms the respiratory tree, and it creates all the ducts and secretory bits of major glands.
Like the liver and pancreas.
Exactly. Liver, pancreas, thyroid. And its structure is almost always simple, so one layer thick, usually columnar or cuboidal, because its priority is function, not, heavy-duty protection.
And you can see that perfectly in the high-yield structures. In the small intestine, it's simple columnar epithelium built for maximum absorption.
Which is why you have those villi and microvilli, just increasing the surface area like crazy.
But then the architecture totally shifts when we get to the respiratory tract.
Right. In the trachea and bronchi, the cells are pseudostratified ciliated columnar, and they are just loaded with goblet cells.
Because the function there isn't absorption, it's clearance.
It's all about clearance. It creates the famous mucociliary escalator.
That's such a great term for it, a little conveyor belt sweeping all the gunk up and out.
Precisely. And knowing that structure just illuminates the pathology. If you have defects in the Dynan arms, the little motors for the cilia,
Like in Carter-Gainer syndrome.
or if the mucus is too thick because of bad chloride channels, like in cystic fibrosis, that whole conveyor belt just grinds to a halt, mucociliary clearance fails, and you get chronic infections.
And so that simple failure of an endoderm structure is the root cause of the whole disease.
Yep.
And histopathology gives us a quick way to ID this, right? The sources mention specific stains for those mucus-producing goblet cells.
Two classic ones. First is PAS, periodic acid Schiff. It stains carbs and mucin this bright pink or magenta color.
Okay.
The other one is Alcian blue, which is more specific. It targets acidic mucins and turns those goblet cells a really deep blue. That's your signature for inner plumbing activity.
And, this leads directly to a huge exam trap you mentioned, this one involving the lungs.
Yes. So we just said the respiratory tree is endoderm. But people often assume the very delicate, simple squamous lining of the alveoli. They assume that must be mesoderm because it's so thin.
Wait, so you're saying the cells doing the actual gas exchange are not from the same origin as the cells lining the blood vessels that are right there to pick up the oxygen?
I know, it is genuinely counterintuitive. But alveolar type I cells, the simple squamous ones for gas exchange, and the type 2 cells, the cuboidal ones making surfactant,
The ones with the lamellar bodies?
those are both from the endoderm. The thinness is just a functional adaptation for diffusion speed. It is not a sign of mesodermal origin. You have to keep that separate in your mind.
Okay, so let's talk about the cancer link, because this is a perfect example of the body making a bad long-term trade-off. We're talking about Barrett's esophagus.
Right.
The distal esophagus is normally stratified squamous. It's ectoderm. It's for protection. But with chronic acid exposure, the tissue is forced to change.
It's an act of self-preservation, really. The body swaps out that brick wall, the stratified squamous, for a lining that can handle acid better.
So it brings in the glandular, simple columnar epithelium from the stomach, which is classic endoderm.
Exactly. Full of goblet cells. That switch is called metaplasia.
But if the body is just protecting itself, why is that change so dangerous?
Because the cost of that swap is bringing in a new and unstable cell type. You're putting glandular cells where they don't belong, and those specific cells have a high risk of transforming.
And that metaplasia is what leads to
A huge risk for adenocarcinoma. The rule holds perfectly. Endoderm lines glands and tubes, and when cancer pops up from those glandular structures, it is almost always an adenocarcinoma.
Okay, that makes sense. So moving on to mesoderm.
So if we connect this to the bigger picture, mesoderm's role is absolutely vital. It's all about creating smooth, slippery linings, essential for frictionless movement and flow.
I love that slippery wrap analogy. It perfectly captures the two major epithelial types that come from mesoderm. Let's start with endothelium.
Okay, endothelium is the Teflon coating for your vessels. It's a single layer of simple squamous cells. It lines every blood vessel, every lymphatic, the heart chambers.
The endocardium.
The endocardium, right. And its whole job is to prevent friction and to maintain a non-thrombogenic surface, an anti-clotting surface.
And we know this layer is key because it's where von Willebrand factor is made.
And packaged into those diagnostic little structures, the Weibel-Palade bodies.
Absolutely. So histologically, it's pretty simple.
Very simple, flat, elongated nuclei that run parallel to blood flow. Clinically, though, if you're looking at a vascular tumor, like an angiosarcoma, you need IHC.
Immunohistochemistry, the molecular ZIP codes.
Exactly. And endothelium is positive for specific markers like CD31 and CD34. That's how pathologists confirm a tumor came from a vessel lining.
And the second type of mesoderm epithelium is mesothelium.
Right. Mesothelium is the saran wrap that lines your major body cavities, the serous membranes.
So the pleura around the lungs, pericardium for the heart.
And peritoneum in the abdomen. Its job is to secrete a tiny bit of serous fluid, creating this lubricated cushion so your organs can move without rubbing against each other.
Imagine your heart beating thousands of times a day without that. The friction would be insane.
It would be devastating. And just like endothelium, mesothelium has its own markers for pathology.
What are those?
The cells are typically positive for proteins like calretinin and WT1. This is the critical diagnostic link for malignant mesothelioma.
Which is the cancer that's so strongly linked to asbestos exposure.
Exactly, causing that thick, tumorous rind around the lung.
Okay, let's just pause and hammer home that embryology trap we started with, because mesoderm is clearly ground zero for all the confusion.
Yes, let's be very clear. Endothelium is mesoderm, not endoderm. Mesothelium is mesoderm. The only way to keep it straight is to remember the function. If the job is slippery, anti-friction, or vascular flow, the architect is mesoderm.
Okay, that's a great rule. Now, this is where it gets really interesting for me. The ectoderm, the body armor.
Yes, this is all about defense. If a surface needs to withstand abrasion, trauma, dehydration, it's got to be ectoderm.
It forms the external protective surfaces and even some internal ones that get a lot of wear and tear.
And its structural rule is all about defense through layering. It is overwhelmingly stratified squamous epithelium, multiple layers stacked up, a physical barrier.
And this armor is divided based on what you call the wet versus dry rule.
Precisely. You have the keratinized epithelium. That's your tough, dry armor. Think of the epidermis of your skin.
Like a reinforced brick wall.
It's a perfect analogy. It has the stratum corneum, that top layer of dead nuclear cells just packed with keratin. That gives you total resistance to drying out and maximum protection.
So if the tissue is exposed to air and needs to be waterproof, it's keratinized.
Correct. Then you have the non-keratinized type. This is the moist, flexible shield.
Where would you find that?
In high friction but wet areas. The oral cavity, the esophagus, the cornea, and the anal canal below the pectinate line. It's still stratified squamous for strength, but the surface cells keep their nuclei because they're kept hydrated by, mucus or tears.
So all this stratified epithelium has a birthplace, right?
Right.
The basal layer. Why is that so important clinically?
Because that's where all the action is. Regeneration, mitosis, that's the source of all renewal for the tissue.
And therefore?
And therefore, it's the source of almost all the major cancers that come from ectoderm. This means tumors here are primarily squamous cell carcinoma, or SCC, and basal cell carcinoma, BCC.
And there's a dead giveaway on the slide for SCC, isn't there? The keratin pearl.
That is the pathognomonic buzzword. When a pathologist sees that laminated, swirly sheet of keratin inside a tumor, that's the signature.
What does it mean?
It means the tumor cells are still trying to do their original job. They're desperately trying to form the protective armor they were designed to create. It confirms an ectoderm origin and an SCC diagnosis.
So we've used origin as our main principle, but you said we can also just use structure to figure out function.
Yes, another fantastic shortcut. It's incredibly direct.
Structure equals function. So the number of layers tells you everything you need to know about its priority.
Absolutely. Simple epithelium is the window pane. It is one single layer. Its entire design is for efficient exchange and fast transport. Minimal distance equals maximal speed.
And that's the architecture we saw in the inner plumbing and the slippery wrap?
Exactly. Simple squamous for diffusion alveoli, capillaries. Simple cuboidal for active work, secretion, and reabsorption renal tubules, and simple columnar for maximum absorption, the GI tract.
Conversely, stratified epithelium is the brick wall.
The brick wall, 2 or more layers. Its function is exclusively protection. Abrasion, friction, chemicals. This is the architecture of the exterior armor.
But the stratified category has this one really specialized, sort of fascinating outlier that doesn't quite fit the armor description. Transitional epithelium.
Urothelium. It is a biomechanical marvel. It lines the entire urinary tract, so the chelicteses, pelvis, ureter, and bladder.
The mnemonic for that is CPUB.
CPUB, exactly. And its job is not just protection, it's to accommodate massive, rapid changes in volume without leaking.
So it's a stratified lining, but it's stretchable, like a balloon with a protective inner lining. How does the structure even allow for that?
Well, when the bladder is empty, it's all folded up, showing many layers, and the surface cells are these pathognomonic dome-shaped umbrella cells.
Umbrella cells.
They're large, rounded, and they contain these rigid plaques that make them totally impermeable to urine, which can be pretty toxic. As the bladder fills, these cells flatten out, the layers appear to thin, and the whole thing expands. It's functional stratification.
Built to handle fluid pressure. And the cancer here follows that specialty, right?
It does. Tumors that arise from this tissue are called urothelial carcinoma.
Okay, so let's bring this all full circle. We've mapped origin, we've mapped function. What does all this mean for actually diagnosing disease?
This is the ultimate payoff.
It turns out the germ layer is a near-perfect predictor for the type of cancer you'll find.
It really is. The cancer type sticks right to the epithelial type. It gives you an immediate diagnostic map. So endoderm, lines, glands, and tubes.
Which means it's dominated by adenocarcinoma.
Always. Colon, pancreas, lung periphery, Barrett's esophagus, it's adenocarcinoma.
Then ectoderm, which lines exposed surfaces to create armor.
That's going to lead to squamous cell carcinoma, SCC, and basal cell carcinoma.
And finally, mesoderm, the slippery surfaces and vessels.
That gives us mesothelioma from the Searson's membranes or the vascular tumor angiosarcoma. Knowing the embryology gives you a three-choice answer before you even look at the details.
But in the real world, especially with metastasis, location isn't enough. You need those diagnostic tools, the ZIP codes you mentioned.
Absolutely. When a tumor has spread, you have to trace it back to its origin with immunohistochemistry. That's where markers like the cytokeratin, CK7, and CK20 are so crucial.
How do they help?
Well, their patterns are different. For example, metastatic colon cancer is typically CK20 positive only, but lung and breast cancers are often CK7 positive only.
So just by looking at the staining pattern, you can immediately rule out huge groups of possible primary tumors.
Exactly. And if you see TTF1 positivity in a tumor, that's almost a slam dunk, isn't it?
Oh, it's the ultimate shortcut. TTF1 stands for thyroid transcription factor 1. It points directly to only two possible origins: lung adenocarcinoma or thyroid carcinoma. That kind of specificity is just invaluable when you're dealing with mystery metastasis.
The whole system, embryology, structure, stain, it creates this complete diagnostic loop. It takes the guesswork out of it.
That brings us right back to the core lesson we pulled from the source material. You don't need to memorize 1,000 details if you just understand the three architects.
Exactly. Endoderm is the inner plumbing for absorption and glands.
Mesoderm is the slippery wrap for vessels and cavities.
And ectoderm is the exterior armor for protection.
And if you combine that with the simple rule of layering, simple means fast transport, stratified means defense, you've pretty much mastered the essential language of histology.
You really have.
You know, we spend some time talking about metaplasia, that protective switch the body throws under chronic stress, like in a smoker's airway or Barrett's esophagus. The switch provides this immediate short-term protection.
It creates better armor, essentially.
Right. But this raises a much bigger question. One goes way beyond histology. If the body's own protective mechanism, metaplasia, inadvertently creates the perfect long-term environment for cancer to develop, where is the ultimate point of no return? Where is that definitive line between the body successfully repairing itself and actively setting the stage for its own long-term survival to be completely sabotaged?
That is the final layer of biological complexity we'd encourage you to explore.